Assalamu alaikum, ladies and gentlemen. Good afternoon. Welcome to the second session of the Pathology in 23rd Cancer Symposium, Shaukat Khanum. My name is Dr. Sharif Bashir. I am the senior instructor in histopathology at Shaukat Khanum Memorial Cancer Hospital. I'll be the moderator and the co-chair for today's session. To begin formally this session, I would like to invite the chair of this session, Brigadier Shoaib Hashmi. Brigadier Shoaib Hashmi is an eminent histopathologist of the country and holds the fellowship of College of Physician Surgeons Pakistan, Royal College of Physicians UK, and College of American Pathologists. He holds the teaching status of professor and has authored over 100 publications in national and international journals. Brigadier Hashmi has also been awarded a Sitara Imtiaz Military for his eminent services. He's currently working as the head of Department of Pathology and the principal CMH Kharia Medical College. Thank you so much, sir, for coming to this session. The first speaker for this session is Dr. Mudassir Hussain. Dr. Hussain has expertise in surgical pathology with special interest in nephropathology. He also holds a second fellowship, a dedicated fellowship in nephropathology from Canada. He is a dedicated teacher and has published many articles related to nephropathology and other subjects as well. He's currently working as a consultant histopathologist and head of department at Shaukat Khanum Memorial Cancer Hospital. His talk would be related to onconephropathology today. Thank you so much, sir. It is an honor for me to invite Dr. Mudassir Hussain.
Thank you very much. And this is, of course, an honor for me to talk on this definitely very boring topic. Okay, first part of talk would be very boring, and the second part would be less boring. Okay, so there is no conflict of interest and financial disclosure. So what is onconephrology? This is basically a focus on management of kidney disease in cancer, which manifests itself as acute kidney injury, interstitial nephritis, chronic kidney diseases, hypertension, many times proteinuria, such as minimal chain disease, focal segmental glomerulosclerosis, and membranous glomerulonephritis, and also electrolyte disturbances or disorders. And many of these conditions result from cancer treatment, such as on account of chemotherapy, target therapies, immune therapies, CAR T cells or chimeric antigen receptor T cells, and stem cell transplant, tumor lysis syndromes, and some of the other diseases such as monoclonal gammopathy or glomerular diseases associated with the malignancy. So this is a basic structure of nephron, and many of these agents, such as immune checkpoint inhibitors, they are causing minimal chain disease, focal segmental glomerulosclerosis. Some TKIs also cause focal segmental glomerulosclerosis. Lupus nephritis is also a manifestation of immune checkpoint inhibitors. Vasculitis, thrombotic microangiopathy is associated with many of these agents, such as platinum-based chemotherapy and also gemcitabine, mitomycin, and anti-targeted vascular endothelial growth factor receptors. Tubulopathies are associated with the cisplatin, ifosfamide, and also immune checkpoint inhibitors. Acute tubular injury is the most common manifestation of all these conditions, which is associated with the chemical agents, ifosfamide, methotrexate, tyrosine kinase inhibitors, BRAF, CAR T cells, and same is the case with the uric acid nephropathies. IFTA is associated with the Pemtrext and methotrexate. And so on and so forth is these disturbances such as hypokalemia, hypophosphatemia, hyponatremia, hypomagnesemia. They are all associated with the one and other these agents such as target therapies and chemotherapies. So there is no need to cram all this table. This is, of course, this is a very lengthy and very laborious table, but we must know what type of agent is causing what disease. Platinum agent or the chemotherapy causing AKI, acute tubular injury. Ifosfamide is causing AKI and acute tubular injury, cyclophosphamide causing hyponatremia, hemorrhagic cystitis, melphalan causing AKI, hyponatremia, methotrexate, AKI. So AKI is very common in all these conditions. So same is the case with the mitomycin, AKI, hypertension, and so on and so forth. These are some of the targeted therapies. Vascular endothelial growth factor receptors, inhibitors causing hypertension, proteinuria in the form of medium chain disease, focal segmental glomerulosclerosis, and also AKI. Tyrosine kinase inhibitors, which are sunitinib, sorafenib, they are causing hypertension on account of vasculopathies, proteinuria, AKI, electrolyte disturbances, and calcium and phosphorus disturbances. BRAF inhibitors, they are causing AKI and proteinuria and also podocytopathies. EGFR is associated with the hypomagnesemia and glomerular-based diseases. ALK inhibitors, they are causing pseudo-AKI and AKI. Pseudo-AKI is when biopsy is normal, but the creatinine is increased. Kidney cyst formation is also associated with the ALK inhibitors. BCL2 inhibitors, they are also causing AKI. So this is a picture for immune checkpoint inhibitors, how these immune checkpoint inhibitors are working. This is a macrophage and this is a T cell. Macrophage activating the T cell through antigen presenting cells with the help of major histocompatibility complex. And T cell receptors, they attach with the major histocompatibility complex and which cause the activation of T cells. But for their activation, there are some co-stimulators such as CD28 and CD80 on macrophage and CD28 on the T cells. These co-stimulators are also working for T cell activation. But PDL1 is formed on macrophage and PD1 on the T cell, and these inhibitory signals over the T cells with the help of CTLA4 over the T cells, there is inhibition of T cell activation. Here, immune checkpoint inhibitors are working. They deactivate the PDL1, PD1, this connection, and as well as CTLA4 inhibition is also inhibited by immune checkpoint inhibitors. So this inhibition is inhibited, and then there is activation of T cells. So these T cells, they act against the tumor and cure the patient, or at least confine the tumor. The lower part is basically the CAR T cells. T cells are harvested from the patient. Then these T cells are injected with the viral markers. After injection of the viral markers, these T cells, they form a chimeric antigen receptor over the T cells where they act on the tumor cells and lyse the tumor cells into different smaller fragments and destroy the entire tumor. Whenever there are rapid signals, there would be more AKI. AKI would be more because more and more T cells are activated, and these T cells, they directly destroy the tubular epithelial cells. In addition, there is secretion of many cytokines, just as interleukin 1, interleukin 2, insulin-like growth factors. And these all growth factors, they act on the tubular epithelial cells and cause acute tubular injury. Okay, so this is a picture of tumor lysis, tumor cell lysis syndrome. Whenever there is CAR T cell, more and more CAR T cell will be activated. They will destroy the tumor into smaller fragments. These fragments are eaten up by these macrophages. More T cell will be activated. So there will be a burst of T cells as well as the cytokines, interleukin 1, 2, 6, tumor necrosis factor, insulin-like growth factors, and also fibroblast growth factors. All these agents, T cells and these cytokines, they release and they cause injury to the kidney as well as injury to the liver. Okay, Gene. Interferon, they are causing thrombotic microangiopathy, minimal chain disease, focal segmental glomerulosclerosis. Immune checkpoint inhibitors, they are causing podocytopathies, necrotizing glomerulonephritis, vasculitis, and C3 glomerulonephritis. CAR T cells, they are causing AKI and acute tubular injury plus nephritis. So there are many tumors who are directly associated with the different types of glomerulonephritis and the glomerular-based diseases. Renal cell carcinoma is associated with the membranous glomerulonephritis, HCC IgA nephropathy, crescentic glomerulonephritis is associated with the renal cell carcinoma, podocytopathies such as minimal chain disease, focal segmental glomerulosclerosis. They are associated with the hematological malignancies. Waldenstrom macroglobulinemia associated with the CLL, B-cell non-Hodgkin lymphomas, myeloma cast nephropathy, amyloidosis, light chain deposition disease, and heavy chain deposition disease are associated with the plasma cell tumor. But this is a picture of thrombotic macroangiopathy. You can see this is a representative glomerulus. These are our fibrin thrombi within the peripheral capillary loops. There are prominent endothelial cells. So this is called basically a bloodless glomerulus because the blood cannot pass through this glomerulus on account of more and more these fibrin thrombi. This is focal segmental glomerulosclerosis. This is low power and this is high power. You can see this is the area of segmental sclerosis where the peripheral capillary loops are closed and this part is attached to the Bowman capsule. So this is a typical picture of focal segmental glomerulosclerosis. Membranous glomerulonephritis, and this is crescentic GN fibrinoid necrosis, and this entire crescent is almost 90%. This is circumferentially involving the glomerulus. Okay, Ji. So now is start of interactive session. Please pull out your mobiles. Please. डॉक्टर उस्मान मोबाइल जरा खोलें जरा अपना खोलिए नहीं ऐप नहीं डाउनलोड करनी सो देयर वुड बी अ क्वेश्चन एंड आंसर सेशन कोई एग्जाम नहीं है कोर्स ठीक नाम नहीं आएगा दैट्स फॉर श्योर ओके जी केस नंबर 1 diagnosed with small cell lymphocytic lymphomas and chronic lymphocytic leukemia in 2015 treated with rituximab cyclophosphamide bendamustine and now there is increase in creatinine. Kidney biopsy was done. So this is a biopsy. I will explain later. First you see the biopsy. This is CD20. Okay. Now the QR code is in front of you. Scan करें ठीक है और आंसर करें.
And also we have around 30 participants online. They can
Okay.
also scan from their screens. They can just pull out the camera app and just click on the QR code. The link will show itself. Just open up the camera app and click on the QR code. It will take you to a Google form and you can just submit your poll to it.
First is interstitial nephritis, severe acute tubular injury, B, renal tissue involved by CLL, SLL, minimal chain disease, focal segmental glomerulosclerosis. I'll ask from Dr. Sharif. So what is the
So
poll
responses are
result?
coming in. I think we can wait another 10-15 seconds.
10 more seconds only.
Again, just open the camera app and click on the QR code. You will get the link for the form and then you can just submit your options. Yes, we are getting responses. Good.
The next picture is more interesting, I think, and that I haven't shown. ठीक है, अब ठीक है ना? Okay. Okay जी.
So, as far as the poll is concerned, we have a tie between the first option, moderate interstitial nephritis, and the third option, renal tissue involved by CLL and SLL. 7 votes each.
Okay, normal glomeruli, so there is no problem with the glomes. Tubules are almost back to back, but this infiltrate is, of course, this is concerning. Okay. CD20. There are many cells which are CD20 positive. Usually, and almost 99% of the time, in the kidney, we have T cells. We don't have B cells. Maybe rare, only rare, less than 1% are B cells present in the kidney. So why these cells are coming? Patient has the history. This is CD3. This is CD23. Okay. Before 23. I diagnose, of course, after 23 with the help of metapathologists. Okay, ji. So, case number 2. 42-year-old male diagnosed with chronic myeloid leukemia in 2007, treated with imatinib, deranged RFTs, creatinine increase from 0.7 to 3.5. HNE, Holmes, so everything is in front of you. Okay, ji. Again, QR code and number 1, minimal chain disease. Number 2, acute kidney injury. C, moderate interstitial nephritis and acute kidney injury, hypertensive nephropathy, and unsampled focal segmental glomerulosclerosis, which I give almost 50% of the cases unsampled focal segmental glomerulosclerosis. 10 more seconds for the answer. 10 more seconds. 7, 6, 5, 4, 3.
So, the most common answer is moderate interstitial nephritis and acute kidney injury. C.
Okay. That's good, I think. Okay, ji. So glome was normal. So this is the part of area which is more concerning here. We can see that there are few eosinophils and lymphocytes. You can see the tubules. They are not back to back of forth, but there is no thickness in the tubular basement membrane, which is required for atrophy. So this is severe acute tubular injury in the form of there is loss of brush border, there is some sloughing off of epithelial cells, and there is significant infiltrate. So imatinib is directly involved with the interstitial nephritis and acute tubular injury. So question was absolutely correct. Number 3, patient has a history of classic Hodgkin lymphoma treated with bendamustine, gemcitabine, Gemvino, enoxaparin. Now acute kidney injury with raised creatinine in January 2022, subnephrotic range protein urea. Kidney biopsy was done in January 2022. Okay. You can see again if I am in a hurry. Number 1, focal segmental glomerulosclerosis. normal glomeruli versus minimal chain disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, acute thrombotic microangiopathy. Okay. Ten seconds. Sharu announce result.
So the most common answer is C, membranous glomerulonephritis.
Membranous glomerulonephritis. Okay, G. So if you see here, you can see this is one of the glomerulus with mesangiolisis. There are vacuoles within the mesangium. Okay. And there is thickness of the basement membrane, of course, but there are no spikes at all. Prominent endothelial cells, and there are, of course, fibrin thrombi. These are very prominent fibrin thrombi, mesangiolisis. There is no spikes at all. And I gave a history here that there is no nephrotic range protein, urea, and these are the thrombi, the very prominent thrombi. So the answer would be acute thrombotic microangiopathy. And gemcitabine is very notorious for thrombotic microangiopathy. Now the case number 4, ovarian serous carcinoma, stage 3, with malignant bowel obstruction, treated with gemcitabine, etoposide, carbotaxel, drug-induced cardiomyopathy and acute kidney injury in March 2022. Now we have again biopsy. And this is the best. This is, and this one is the best picture. Okay. Membranous GN, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, acute and chronic thrombotic microangiopathy, and acute kidney injury. So, what it can be? People seems to be tired. Seems to be tired. 5 seconds left. 2, 1, and 0. G Sharabhai.
So the most common answer is D, acute on chronic thrombotic microangiopathy. Now there is a tie between membranoproliferative and acute and acute on chronic.
In the last case was also treated with the gemcitabine, and this is also treated with the gemcitabine. Okay. But the difference is, to some extent, difference in the morphology of the case. See, there is wrinkling, there is thickness, prominent endothelial cells, no typical vacuoles in the mesangium. But you can see that these are fragmented RBCs present in these arterioles. Okay. And there are some fibrin thrombi within the peripheral capillary loops. There is some double contouring, but it's not very obvious in this picture. But the main thing is these fragmented RBCs which are present in this arteriole. So this is acute and chronic thrombotic microangiopathy. So in the acute, there are prominent fibrin thrombi. Usually there are no fragmented RBCs, and there is no onion skinning in the artery. So this is acute and chronic thrombotic microangiopathy. Okay. Diagnosed with left breast IDC grade 2 in 2023, treated with tamoxifen, radiotherapy, tacrolimus, and steroids, then developed nephrotic syndrome. This is kidney biopsy to see what is in the nephrotic syndrome. Okay, so there are 4 common causes of nephrotic syndrome. This may be one of them. Focal segmental glomerulonephritis, MPGN, minimal chain disease, membranous glomerulonephritis, and severe AKI or ATN. आसान केस. जी.
So we have a clear winner in this one, FSGS.
Okay, so tacrolimus is very notorious for causing chronic condition in the kidney, tubular atrophy, and also there is definite area of segmental sclerosis, which is perihilar as well as NOS type. So there are sclerosed areas attached to the Bowman capsule, and there is closure of peripheral capillary loops, some hyalinosis. So this is definite area of focal segmental glomerulosclerosis. Okay, perihilar NOS type, and tacrolimus is the main culprit. 53 female, myeloma 2013, treated with XRT, thoracic spine, lenalidomide, bortezomib, cyclophosphamide, developed chronic kidney disease. Kidney biopsy was done. Okay. So question number 1, acute kidney injury. Severe acute kidney injury secondary to myeloma cast nephropathy, interstitial nephritis, unsampled FSGS, minimal chain disease, hypertensive nephropathy. So we just have 5 more seconds. Ji, Sir Sharif.
Again, we have a clear winner, severe acute kidney injury secondary to myeloma cast nephropathy.
Okay, good. So glomes are normal. There is no increased mesangial cellularity, no endocapillary proliferation, no segmental sclerosis. But tubules are severely injured. There is significant these degenerative changes, and there are many tubules which are dilated by these casts. There are cracks in the casts, and these casts are surrounded by these macrophages, inflammatory cells. And this is the trichrome stain and showing the cast. Kappa is dominant, kappa is positive, and lambda is negative. So there is monoclonality. And of course, this is severe acute kidney injury secondary to myeloma cast nephropathy. So this is the second last case, case number 7. Patient is diagnosed with papillary thyroid carcinoma, now developed nephrotic syndrome, kidney biopsy was done. This is the PE stain. overexpression of the pH stain. Okay. So answers may be MPGN, membranous GN, FSGS, hypertensive nephropathy, and severe acute tubular injury. Okay, Sharif.
So the most common response is membranous glomerulonephritis, option B.
Okay. So we can see there is some IFTA in the form of tubular atrophy because the tubules are, to some extent, they are giving some spaces to interstitium and with interstitial fibrosis. And these are the glomes. There is thickness in the membranes, and you can see that there are clear spikes over the epithelial side. There are subepithelial spikes. Okay, again, there are subepithelial spikes. So this is membranous glomerulonephritis, which is a secondary because the patient has a history of papillary thyroid carcinoma. After the surgery of tumor, membranous glomerulonephritis was washed away. So its kidney was almost normal. So the last case, 51-year-old male, Hep C positive, then developed hepatocellular carcinoma, kidney biopsy was done. IgG, C3. Again, see the picture. Okay, ji. Membranous GN, FSGS, MPGN immune complex type, post-infectious GN, IgG nephropathy with proliferation. Last. वैसे लोग थक गए हैं अब. हाँ भी शरीफ.
So the most common answer is MPGN immune complex type.
Absolutely. Okay, you see this is of course a proliferative glomerulus with lobulated architecture. There is significant double contouring in the basement membrane. And these are the clear areas which are present within the two layers of membrane. And here we can see in IgG, there are strong deposits of IgG and as well as the C3. So this is immune complex type membranoproliferative glomerulonephritis, which is associated with Hep C as well as directly associated with the HCC of this patient. MPGN immune complex type, and thank you very much for your attention. Thank you.
Thank you very much, Dr. Mudassir. It was not as boring as you said at the start. I saw all the young pathologists, budding pathologists, very, very much absorbed. And it was a topic which one usually misses, and you covered. It's a very, very important one for all these youngsters. Thank you very much. We'll do the Q&A section at the end.
Thank you very much, sir. Thank you. Okay.
Thank you, Dr. Hussain. For the next talk, I would like to request Dr. Melissa Upton. Dr. Melissa Upton is well recognized for her contributions in education and was inaugurated as the president of American Society of Clinical Pathology. She is passionate about patient-centric work in an association that advocates for the professions of laboratory professionals. Dr. Upton is an emeritus professor of pathology and serves as director of GI and liver pathology services at University of Washington, Seattle, USA. So over to you, Dr. Melissa.
Hello, I'm Melissa Upton, and I'm an emeritus professor of pathology at the University of Washington in Seattle and a past president of the American Society for Clinical Pathology. I wish I could be here with you today. I have many dear friends and colleagues and former trainees from Pakistan, and someday I hope to travel there. But in the meantime, please know that I wish you every success, not only in this conference, but in your careers and lives. And I'm here today to talk to you a bit about that, because one of my key passions is mentoring. So first of all, I have no commercial interest to disclose. And if you take nothing else away from this, please take these messages. You are the only person living your life. And there is no single roadmap for life. Other people have taken paths that are not available to you or that may not fit with you. You are not alone, however. The key to life is to show up and to live on purpose. There are many fellow travelers, and joy and success are found in relationship with these fellow travelers who are also living purposeful lives. So surround yourself with other people living purposeful lives. You're a human. You're not a machine. So recreation, constantly taking care of yourself, renewing your creativity is essential. So what are the things I'm going to cover? I'm going to talk about what a mentor can do and how a mentor differs from a sponsor or a coach. You might need all three. How to develop an effective mentorship. What is the hidden curriculum? How do you make choices about your career direction? And these questions are for both the mentor and the mentee, because honestly, we're going to be both at multiple stages in our lives. Who am I? What are my core values? A mentor can help with that, hopefully. How can I define my goals and objectives at each stage of my career and my life? Do I say yes or no to an opportunity? How can I manage my time? How can I achieve better balance between my job and the other parts of my life? And how can I work more effectively with my supervisor, chair, or director? So who am I? I am not a verb. I am a process. I am a continually changing being. I'm not a single accomplishment. I'm not a single destination. I am a flow of consciousness and a human body on a particular journey. And who I am is going to be answered one step at a time in relationship with other people and with work and projects. It's going to be answered in my presence and my engagement with others and with the work that I'm doing or the creative process in which I find myself. Now, each of us carries explicit and implicit biases. So the implicit biases are preconceived judgments that we snap at very quickly because they're reflexive, but they often reflect the culture that we grow up in. Explicit biases are things that we can see ourselves judging. We know if we're biased toward a light colored room or a dark colored room, or if we have certain notions about a certain type of person or a person of a certain gender. Those are our explicit biases, but we may carry implicit biases toward people as well. And what messages do we take from our culture? So I often find that people say, well, I couldn't be a leader. I'm not a good public speaker, or I'm a woman. I couldn't be a leader. Well, people have a preconceived implicit bias or explicit bias about what a leader looks like. But all of you have the potential to be leaders, and many of you are already leaders in whatever you're doing right now. And what's that hidden curriculum? That set of unconscious, unarticulated cultural assumptions that motivate us. Those aren't necessarily bad, but we want to bring them into the light to know what's motivating us, so we can see if that's functional, helpful, or counterproductive. So I Googled images with the question to Google, what is a leader? And what I discovered is that of the first 65 images, there were only 2 non-white men shown as leaders. And only 2 women appeared in the images, but when they appeared, they were in a group as if they were followers. This actually sets up, for those of us who encounter such images, the idea that I couldn't be a leader in the United States if I'm not a white man. And that is counterproductive. Now, if we look at the dominant culture in the United States, as I mentioned, white men have historically had significantly more leadership opportunities. And they've also set the formal and unspoken cultural rules of workplaces, of training institutions, of the government, etc. Now, Pakistan, unlike the United States, you've already had a woman prime minister. We haven't had a woman president. And within Pakistan, 72 languages are spoken. Now, I know that Urdu and English are the 2 major languages used in educational institutions. However, many people come into your institutions who have very different backgrounds and have a different language. And you know what? Language is a tremendous gift. When we have more than one language, we can think in more than one way. So when you have 72 languages potentially, you have many more perspectives possible to be shared in your workplaces and your training institutions. What are the opportunities there for people from all of these different backgrounds to advance? Does the field of pathology, does healthcare in general in Pakistan exclude or include voices of all of these different groups? And when I use the term minority here, I mean the people who do not comprise more than 50% of the population. And I know with 72 groups, no one is more than 50% there, but certain groups have historically had more dominance. And have those groups then set unspoken cultural rules or modes of behavior that dominate? Now, I also know that, like the United States and like every country in the world, you are facing severe workforce challenges in the fields of pathology and laboratory medicine. Unlike Europe and the United States, where we have one histopathologist for about 15,000 people, you have one for 450,000 people, fewer than 220 histopathologists for 220 million people. That's difficult. Only 37,613 laboratory technicians throughout the country, and this is the citation on the left, from which I found these statistics. In the United States, fewer than 1% of our medical students choose pathology as a specialty, and we are currently training fewer than half of the technicians and technologists that we need, and they're often being hired away by high-tech companies. And when I was president of ASCP, I went to an international meeting where I met with presidents of multiple pathology societies from around the world. This is true everywhere, whether it's an incredibly bad disparity or just a very bad disparity. We are all struggling globally with keeping people, with recruiting people, with having students select our professions. So we need to work together on this problem. But mentorship is critical for keeping people happy, keeping people successful. And there's a recent article in the American Journal of Clinical Pathology that one of the major ways that laboratory professionals, technologists and technicians could be kept in the same workplace was when they had opportunities to get additional certifications, ASCP certifications, to keep growing, to keep learning new skills. So as mentors, we need to help people find ways to advance, thrive, and grow. Another cultural paradox is that we train people as individuals, and that's essential too. They have to be competent. We all have to be competent. We have to know our stuff. And we focus on this a lot, though. We test people by exam scores and grades. To be certified in many countries, exams are necessary. And consequently, our admissions policies, also our recruiting, is often on lazy criteria. We look at scores, grades, metrics like number of publications. We don't necessarily look for the real world skills of cultural competency, the ability to work on diverse teams, to collaborate, to cooperate. And that's going to be essential because our teams are diverse with respect to training, age, disciplines, cultural backgrounds. Otherwise, we can't thrive. We don't need 15,000 informatics people in a city. We need also hematopathologists and people interested in lung pathology and people interested in quality. So we have to have a diverse group of people. Now, there have also been studies that have shown that joy and happiness and well-being are relational, discovered when we lose ourselves in a process associated with growth rather than accumulation, and explorational. Pathology, laboratory, and medicine are patient-centered teamwork, constantly changing and explorational. And in fact, young children like us would rather explore than get rewards. Well, yes, we need to earn enough money to support our family, but most of us, a lot of our satisfaction comes from solving interesting problems, having a chance to grow, having a chance to develop, and having that recognized and valued by more than money. So what can a mentor do, and why should you find a mentor? Well, I personally think the most important goal of this process is gaining self-awareness and helping us figure out how to grow, personal growth. Good mentorship is an active process where we explore these issues with someone else. And that person helps us discover what are our goals and objectives. Ideally, a mentor can help you become more self-aware, more self-reflective, more self-analytical to refine your goals and objectives, strengthen your ability to analyze the resources and coaching you need to reach your goals, and teach or coach you in specific skills or attitudes. Now, you can read this slide from either the perspective of being a mentee or a mentor. This is what you're looking for in a mentorship relationship. And I have mentors, and I am a mentor. And all of you should be in both roles all the time, because by mentoring, you also grow in understanding of yourself. When do you seek a mentor? When should you seek a mentor? I personally think mentors are helpful anytime along your path, including maybe especially when you don't even know what questions to ask. Ideally, a mentor is more knowledgeable or experienced in the area for which you seek mentoring, but not always. They can just be a really great listener to reflect back your concerns and questions. And you may need more than one mentor, depending on your goals. I also think when everything is going great, what are your stretch goals? What's your next? What are the things you haven't considered doing or exploring? And when you're discouraged, don't avoid talking to people. This is often when we need perspective, new approaches, reassurance, a chance to be witnessed and supported, to think out loud. And half of my job with my mentees is usually saying, you're doing just great. What are you worried about? Tell me why you're concerned about what you're doing. They don't know how well they're doing. And sometimes it's essential to have someone just reflect that back. Look at all the things you've accomplished in the last 6 months or the last year. That's very, very helpful. It's validating because most of us are living within one slide to the next, one problem that we solve to the next. Stepping up, getting a bigger perspective is essential. A mentor might not be able to write letters of reference, and I always start with this. If I'm talking to you, I may never witness your direct work product. I might not have done any QA on a slide that you've read or checked your diagnosis. So it's not reasonable necessarily for you to expect that I'm going to be someone who can help you with a letter of reference. Also, a mentor might not be able to place you first. As a mentor, you may not be able to place your mentees first. You have a day job. You have a job with expectations from your chair, and you're usually in a voluntary role when you're mentoring. So the mentee may not come first. And of course, that means we can't always meet the expectations of our mentees. Also, my skill sets may not be right. I might be able to help you. I can't help you with grant writing. I can help you with public speaking. I can listen to your talks and give you feedback. Someone else is the person who might give you advice on writing grants or going over your grants with you. Someone who's a skilled person at getting funding. And I might not be able to connect you with others or promote you to others. Mentoring doesn't necessarily imply an investment of my investment in your career or your advancement. It's a voluntary relationship. Now, how do you craft an effective mentorship? As you've already seen, it's not passive, in my opinion. My mentees have to come to me with clear problems that they want to talk about at this meeting. Here are my goals and objectives to talk about for this meeting. I'm going to define with them in advance the expected timing and frequency of meetings. If they want to meet every day or every week, I don't have that time. I might be able to meet every month or once a quarter. We need to negotiate around that. And so if someone needs more frequent meetings, they may need to find someone else. But these are conversations to have at the beginning of the process. It's important to define how we meet: online, in person, by Zoom, taking a walk outside work, at work. This is negotiable. It should be negotiable. Outline the action items or expectations for each meeting and discuss how things are going. If we figure out we're not really getting anywhere and there might be someone more helpful to that mentee, great. I don't have any hard feelings. They might meet with me once and find someone else. They might meet with me frequently. It shouldn't be something that becomes a sticky interpersonal conflict over whether the mentorship relationship continues. This should be an opportunity to come in, get some help, find other mentors. And I always make this clear in advance. I may be the best mentor for you for a period of time. You might find someone else that's more helpful at this stage in your career. Open-hearted. What are the pitfalls? Well, I've already implied passivity. For me, a mentee can't expect to come in and have me tell them what to do, because I'm trying to build self-analytical, self-reflective awareness. Assigned mentors. This is very common in the corporate world. And that can sometimes work, and we'll talk about that in a minute, but it can be very clunky and clumsy with uncertain results. And it may be because the two people just don't match in terms of their personalities, but also if the mentor who's assigned has power over the mentee is not going to be able to be fully honest. So that mentee may need to find other mentors in addition to the assigned mentor. Now, selecting a mentor is also an art, and this involves, again, activity on the part of the mentee to figure out What kind of advice do I need? What are the problems I want to talk through? What are my gaps in knowledge or skills? And think about some possible mentors. But also, honestly, mentors have tremendous limits. I'm not a psychiatrist. I'm not a social worker. It's not appropriate for me to do a medical assessment of my mentees. So if someone is struggling with problems that really are not centered in a mentee-mentor relationship, I'm going to encourage them to consult a different professional. They may need legal advice. They may need formal coursework or additional training. That's not something I'm going to provide as a mentor. Now, counterproductive mentors, sometimes we can learn from them how not to be a mentor, but I'm also responsible for some of the counterproductive mentors I've had because I used to have the tendency to pick people who were a lot like me. Well, guess what? They didn't have any perspective. If they're too much like me, they're not going to have a different approach, a different way of looking at the world. So sometimes it's really important to pick someone who's quite different from you. Some mentors are more interested in replicating themselves than in supporting people with different skills, directions, and aptitudes. And they can have the attitude of my way or the highway. I can't, Chris, come in. Come in. Hello? I'm recording a talk right now. I'll be out in a little while. I don't know. Sweetie, I don't know. Hello? I recorded it once. I lost the entire thing. I want to get it done. Wants you to do what they say, and has no negotiation around that. So the my way or the highway. And also the history of abusive relationships. Sometimes it's very important for you to ask about a mentor in person with another person, so you can sense by their body language or by their voice, if they're not going to tell you directly, but you can sense if they have hesitation about encouraging you to pick that person as a mentor. And that's important too. You don't need to have any kind of abusive relationship in your mentorship experiences. How can a mentor help you within your workplace? So I mentioned that sometimes it's counterproductive, but sometimes it can be very productive, especially if you're smart about how you use that relationship, because that individual can identify ways to improve interprofessional communication in that workplace. They may help you to clarify the policies and procedures, and they can provide transparency about the expectations and the ways to advance that may not be overtly stated. They can help foster altruism, teamwork, and a supportive professional community. And they can help to define models of service leadership and the types of additional training necessary for you to be successful. They may be able to help you decide and know better about what you need to do to advance. So let's talk about this hidden culture that I've mentioned before. This again is where that workplace mentor can help. You can ask them, what are the expectations for promotion, for leadership opportunities? These are not usually provided in the goals and objectives we get at orientation, by the way. Who has the power here? Who really makes the decisions? It might not match with the org chart. There may be someone who's very powerful, who doesn't have that title on their name. Can decisions be questioned? I want to know that. I tend to ask a lot of questions. But if I'm going to get punished for asking questions, I better know that before I start asking those questions. Because then I can ask the question outside the meeting or to someone else. Is the culture based around principles or personalities? Sometimes institutions have a mission statement, But certain individuals actually dominate the way the culture goes, and it doesn't align with the mission statement. So that's important too. Is the culture family friendly? Accepting of personal life? Is there flexibility if my child gets sick? Do women get promoted? If so, at the same speed as men? Do people from marginalized or minoritized groups get promoted and included in positions of power? If I'm from one of those groups, I'd prefer to know in advance that there's no hope for promotion, because then I'll get less frustrated, or I might go elsewhere. Are there unspoken expectations about dress? Are there unspoken expectations about working after hours or on weekends? I tend to work really long hours. And when I remember as a resident showing up on Saturday and Sunday morning, and my chair saying, well, I'm so glad you're here. Everybody else is lazy. Well, they weren't lazy. No one ever told them that the expectation was to show up on Sunday. And I remember reflecting, I'm glad I'm here on Sunday, but that's pretty unfair if that's the expectation. And no one ever told them that. And they're being judged harshly for not showing up on Sunday. Now, what about a mentor or a sponsor? Mentorship is typically a one-way relationship, not always. In my experience, I try to craft a two-way relationship, but the energy, the advice, the suggestions are typically flowing in one direction, with the mentorship providing support and advice, but with no expectation of a payback from the trainee or the mentee. In contrast, a sponsorship is different. A sponsor champions a project or an initiative that the protege joins. The sponsor uses power, prestige, and networking to advance the protege's career and expects a return on investment. So here's the example in academic pathology. I invite a junior faculty member or a trainee to work on a project with me. I expect them then to write the abstract and submit it to the meeting and to attend the meeting, present the poster or the platform. In exchange, I'm going to introduce them to people. I'm going to stand with them at the poster. And when people come up, I'm going to introduce the people I know to the trainee. But I expect the trainee, as I said, to write the abstract, to do the research, and also to finish the paper. The authorship can move around. If they don't do all of that, they might become third, fourth author. But I'm going to set those expectations in advance. And I am, even if they end up fourth author, they're getting something out of that experience. And I'm getting something out of that experience too. So that's a sponsorship. Well, what about coaching? A mentor usually gives holistic perspective, big picture perspective. A coach is focused on specific, timely feedback and instruction for a defined set of skills. A mentor is usually personalizing the advice to that particular person, that particular mentee, providing support and advice for that mentee. A coach might use standardized approaches. Everybody needs to learn how to cut lung sections in the same way with the same thickness. The mentor can talk through what you hope to accomplish and they can provide general directions. Again, the coach will be very specific and focused in how they train you. And a mentor is not grading or measuring your performance, whereas a coach is going to measure your performance in order to assist with your progress and also to perform a needs assessment. So these are different roles. Most of us need both at different times, maybe simultaneously in our lives, but know that these are different roles, mentor versus sponsor versus coach. I'd also like to talk about how you learn. And Howard Gardner, an educational psychologist based at Harvard, developed the theory of multiple intelligences, and this is his website: verbal linguistic intelligence, logical mathematical, visual spatial, musical, bodily kinesthetic, naturalistic intelligence, interpersonal between us and others, intrapersonal, awareness of our own moods. Actually, in our profession, we need all of these. Stereotypes aside, where people think we live in the basement and don't talk to anybody else, we're interacting with other people all the time, and we're better at our jobs if we have emotional intelligence about ourselves. Probably the only aptitude we don't use in pathology and laboratory medicine is musical. However, Dr. Gardner recognized that each of us has a constellation of these different types of intelligence. For some of us, one or two may dominate. For others, all are equally strong. So as we're working with other people, you may want to notice, like, what the intelligence that I have particularly strongly, and what other intelligences are apparent in the people with whom I work, because that can build complementarity and good teamwork. How do I decide what to do with my career? Well, I think it's very helpful for us to think about what's most important to us. Are there activities we don't like? Are there things that we need to do to feel satisfied? I love to mentor. It's one of my #1 passions. If I couldn't be mentoring and teaching, I would not be happy. So I gravitated toward being in an academic center where I could be doing that. Do you love to write papers? Do you love to do research? Are you interested in working with people in other specialties? How do you decide what to do with your career? Aptitudes. What comes easily for you, what comes easy for you is not easy for everyone. So an example is some people are extremely skilled at statistics and love to think in epidemiological terms. I thought I was going to go into epidemiology, but that's not my skill set. I'm a visual learner. So looking at slides, being at the microscope played to that skill set for me, that aptitude. What flows naturally for you? I find that many people think that what's easy for them is easy for everyone, and that is not true. That's a clue about your aptitudes. What were your favorite ways to play when you were a child? That's also a clue about what kind of activities you're going to be happy doing as an adult. If you had to move, if you needed to do sports, you're probably going to need to incorporate some kinesthetic and physical activity in your job to feel truly satisfied, or make sure you have time to do that outside of work. Values. What are your core values? Do you have ambition for specific accomplishments and achievements? Do you need time alone or time with others? Are you single-mindedly focused on your work? Or do you need time for activities outside of work? Are you a generalist? Are you a specialist? There's no right or wrong answer here. This is about knowing yourself. And a mentor can help ask these questions to help you figure this out. So this is a slide that is from one particular website you can find. If you Google or search for core values, you'll find lots of lists. Again, there's no right or wrong here. Are one of your core values intellectual status or vocation or money versus environmental stewardship, public service, religion, spirituality? You get to pick what's most important to you. And so I recommend to my mentees, go through a list like this, pick your top 10, go through and just pick your top 10 values, then narrow them down to your top 5 on this list, then your top 3. And that's really going to help you. It's really going to help you know what's most important in your life and in your work life. And you may want to do this several times or do it in different stages of your life. Because at one point in your life, having a family, starting a family may be very important. At another point in your life, you've raised your kids already. And at that point, actually for me, when my kids got old enough, that's when I started volunteering at the national level. I didn't have time for it when I was raising children and working full time. So how you live your life and the decisions you make about your life are not going to be static, I hope, because your needs and your values will evolve over your lifetime. How do you know if you're making progress? Well, this is something a mentor can help you with. Where are you trying to go? What are the stages along the way? And how will you know when you arrive? And I would say beware of the word should. Every time you think should, it's usually someone else's voice, and you need to be true to yourself and how you learn best and what you think is important. An example is getting exercise. For some, if you think I should go to the gym and lift weights, if you hate doing that, why not take walks or swim? There's so many different ways that you can be engaged with health. You don't have to do what someone else does and think somehow that's a should for you. A mentor can help you refine your goals and objectives. So too often, and this is the way I used to make goals, they're vague and non-specific. I want to understand GI pathology better. Well, the best GI pathologists in the world still have that goal. Become a good pathologist. Most of us are always trying to become even better. Find a better job. What does that mean to you? So SMART goals are specific, measurable, achievable, relevant, and timely. So a better goal would be, I will read 3 chapters of a GI pathology textbook within 8 days, or I will make a list of the specific histopathological findings that differentiate ulcerative colitis from Crohn's disease. Something specific. Then I will know that part of GI pathology better. Revise and update my curriculum vitae within 4 days and apply to 5 jobs in my discipline within 6 days. I'm just throwing that timeline out there. But if you really want to find a different job, the first step is going to be revising your CV, thinking about what kind of job you want. That may not be fast, but it needs to be specific, measurable, achievable, relevant, and timely. Now, Bloom was a psychologist who wrote a taxonomy around goals and objectives. He broke goals and objectives down in a very detailed way around 3 major domains: knowledge, which had to do with cognitive, mental skills, psychomotor, manual or physical skills, and affective, emotional intelligence, understanding self and others. And I think this is very important, because pathology as a discipline involves all of these. And when we think about something like an autopsy, it definitely involves all of these. So if I came to you and said, I'm really struggling with my autopsy skills, well, which skill? Is it the knowledge part? Is it the psychomotor part? Is it the emotional experience of being around the issues of death and dying? Maybe all of those. But until we unravel which domain or domains I need to look at to refine and set specific goals and objectives, I'm just going to be dealing with a vague set of problems. And so Bloom broke this down. So here's an example under the knowledge domain. We start at the basic knowledge level of facts. What are the most common risk factors for deep vein thromboses? This is out of the New England Journal. Comprehension, what is your differential diagnosis for this person with a hot, swollen leg? Application, why do you think she might have a pulmonary embolism? Analysis, well, how would your thinking change if I told you that this is a 60-year-old man? Synthesis, based on our discussion about the prior patient, can you formulate an approach for this new admission? Well, now can you take this knowledge and apply it to more than one patient, maybe a diabetic patient versus a patient with a history of vascular disease? And then finally, full evaluation, where we integrate all of these skills in under this domain, considering the pretest probability and test characteristics. Can you justify your treatment plan? So this is all in the knowledge domain. If we look at the psychomotor domain, we start with perception, where we're looking at listening, observing, perceiving, recognizing, sensing, smelling. We move to the set of mentally, emotionally, physically being ready to act. So we start to set ourselves in a certain posture. We make sure we have certain tools available. Then guided response. We practice these skills. Maybe our coach is showing us first sectioning the lung, showing us how to section the lung, and then we imitate that. We're operating this under supervision, we're practicing, we're trying. Then we get to mechanism. We can perform this particular skill with increasing efficiency, confidence, and proficiency. We have complete overt response. We can start to perform this automatically, habitually. We set the skills in place and we can execute this habitually. But then adaptation, we can reorganize and adapt the set of skills for a new or different problem or situation. And finally, we can completely redesign the approach. We're so proficient in this psychomotor domain that we could design and build a completely different way of doing this particular, solving this particular problem. So designing, combining, composing. Affective domain. We're developing emotional intelligence. We're clarifying our values and building a moral vocabulary. And we're working in a system of shared values. So first, we receive by attending to stimuli that we receive, listening, becoming aware, paying attention. We respond, we start to answer, we care for, we communicate, we follow, we obey. Valuing, we attach a value or worth to something, we start to assume responsibility, we initiate, we exhibit loyalty, we show continual desire for something. Organization, we conceptualize the value and resolve a conflict between it and other values. We arrange, we balance, classify. Again, each of these is an action verb in the list below. And then finally, we internalize that value. We integrate that value into the value system that controls our behavior. We act upon, we advocate, we defend, we exemplify, and maybe we modulate. Maybe we understand, incorporate this value, and alter the value, change the way the value is implemented in the place where we work. Now, how do I balance my work and my personal life? Well, we actively manage our time. We make deliberate decisions. We acknowledge that we're humans, not machines. And I always have to remind myself and others that the laws of physics apply to people too. You have to add energy to a system to maintain momentum. We have to renew our energy, sleep, eat, drink water, take breaks. Entropy is real. Organization and order are not self-sustaining. So if we set some guidelines and give people a set of principles, that orientation, we have to remind people of these principles periodically because humans move away. Entropy exists. Work-life balance. I like this time management matrix developed and published by Stephen Covey in his books, First Things First and 7 Habits of Highly Effective People, where he classifies things in terms of whether they're urgent, not urgent, important, not important. So let's delve into this a bit. So the urgent and important are very easy. And so is quadrant 4, the not urgent and not important. So urgent and important, you all know what this is. You're carrying the on-call pager or the on-call cell phone and it goes off and you have to respond to that patient care issue. You're on call. You either have to do the frozen section or you have to talk to the clinician or respond to an emergency or a machine goes down in the lab and you have to attend to that. This is urgent and important. Non-urgent, non-important, junk mail, time-wasting activities, notifications for inessential apps, turn them off. A ringing telephone, if you're not the person who has to answer it, turn off the ringer. You can check the phone messages periodically, but you don't need to be interrupted by the urgency of that phone that pulls your attention away when it isn't necessary for you to answer every phone call. Now, discernment is also really important for this quadrant 2. Not urgent, but very important. Playing with your children. So your children are going to come to you and say, Mommy, Daddy, can you play a game with me? Can you throw a ball with me? Can you play soccer with me? I know you might call it football, we call it soccer. Well, if you say no, I'm busy right now, I'll come in 15 minutes, in a little while. And you do that enough, they won't come. And before you know it, you don't even notice that your children are not asking to spend time with you anymore. Same with your partner or your friends, your spouse. If you put them off, if you don't respond, if you delay getting back to them, postpone those connections, they won't come back. So be aware of this. The urgency will not be there. So we have to be attentive. We have to pay attention. We have to prioritize these important things. Making time to exercise. Nobody's going to call you in the middle of the work and say, time's up, you got to go exercise. You may have to decide that I'm going to take 5 minutes and walk outside for 5 minutes and come back to work, freshen my thinking, take a break. I need to go to work after I work out. I need to go to the gym and work out first, whatever you need to do. Personal growth. Nobody's going to tell you you have to take this course. You have to read this book. You're through medical school. The exams are over for the most part now. So it's up to us to decide which courses we take, which lectures we listen to, which talks we look at online. Do we spend time scrolling and mindless things on Instagram, or do we actually listen to an audiobook on a topic that we need to know, or that we'd like to know, that would be interesting to us, that would feed our spirit? Recreation. We have to recreate ourselves, our optimism, our hope, our energy every single day. And you get to choose what you're going to spend your time on. It's precious. You're the CEO. You're in charge of how you spend your time often. Not all the time. You have a boss, you have a supervisor, and you have some choices. So execute the choices you have. Thinking, planning, brainstorming, being creative. So again, you're going to constantly hear this ringing of the phone, the doorbell, the app. Turn it off. The urgent things will shout down the essential things, and the things we want to ignore are those urgent, unimportant things. You have to put a fence around these important things that aren't getting your urgent attention. You have to build a fence around them and protect them with your heart, mind, and energy. Now, the urgent and non-important also require some discernment. Only you know which phone calls can be ignored, which mail or email you can ignore, interruptions that you can ignore. You can put a note on your door. I'm making a video right now. Please don't interrupt me. Things like that. Some meetings you can skip. Some reports you can skip. I had a chair, Dr. Nelson Fausto, who's now deceased, but I asked Nelson once, how are you so incredibly productive and efficient? Because he did multiple things extraordinarily well. And he said, Melissa, I figure out which things don't have to be perfect. That memo doesn't have to be perfect. Doesn't have to be Nobel Prize winning prose. My emails, one sentence is enough. I don't have to write a novel when I'm reviewing a paper. You know right away if the paper's good, bad, needs some revision. Don't waste extra time on things that don't need to be perfect. Nelson was amazing, and that really helped me to know, okay, I need to learn to be careful about what really needs to be right. Like my diagnoses on the slide need to be right. What things, if there's a spelling error, no big deal. No big deal. Add it up. Look at the annual time for the things you're doing. Let's just say you're asked to sit on a committee that's going to require 2 hours of meetings a month. Well, that's 2 times 12. That's 24 hours. Now, maybe you have to prepare 1 or 2 hours for that meeting. Well, that takes it up to 48 hours. Or maybe a whole week in that year. So are you really that interested, willing and able to invest this time in that? What other activities do you need to give up in order to do that? Or are you being expected by your chair or supervisor to just add this into what you're currently doing? Well, do you have the resources to be successful if you're being asked to do that? Is that going to require you to develop a skill that you currently lack? Well, how much time will that take? And what coursework do you need, for instance? Do you need additional information, material, or work from others in order to do this work? Does this align with your personal goals, objectives, and values? If you're an investigator, should you be taking on a major role in a large general medical school course? If you're a clinician educator, should you be reviewing grants? Probably not. So it doesn't really align with your values and your own personal needs, skills, aptitudes. So this is when you want to negotiate with your chair or supervisor and make it evidence-based. Your chair, your director, your supervisor has hired you to solve a problem. He or she is not there to solve that problem for you. But they do welcome an evidence-based analysis. So you go in and you tell them what you need to do that. Here are my proposals, plan A, plan B, plan C. If you ask me to set up a new lab, I can do it in 3 years if I have these resources. I can do it in 1 year if I have these resources. Outline then the tasks you're currently doing. My chair didn't know and still doesn't know all the meetings I go to. So I outlined them. Here are all the things I'm currently doing. That's a full-time job. Now you're asking me to do this, which I estimate will take X number of hours. I can't put that onto what I'm doing now because I'm already doing a full-time job. Which of these things is more important to you? Which one of these things would you like me to assign to someone else? Or would you please assign this to someone else? And in order to be successful, and I know you want me to be successful, here are my estimates for the time and resources that I'm going to need. So it's really essential for all of us to be successful. We don't want to set ourselves up to fail. And our supervisor or chair may not know that if we take this on, that's exactly what's going to happen. So we don't have to whine. We just go in with the evidence and we negotiate because they want us to be successful. But you know what? We might be able to brainstorm with that. Maybe someone else would really love that opportunity, could do it extremely well. And it's really not the best opportunity for me. I don't need to be doing that. Someone else could really benefit from that. That's another thing I always do before I go to my chair. I know other people in my division or in my department. I can think about, hey, that person's never had a chance to chair a search before. Why not? They'd be great at it. I can serve on the search committee, but I don't have to chair that search. You know, these are the things you can help your chair, help the people in your division, and help yourself in many ways by focusing on things that align with your core values. I also want to share something my husband reminded me of that comes from warfare of all things, but in some ways we're in a battle in our daily lives often. If an army is engaged in battle, what is the difference between retreat and withdrawal? Well, if I'm forced to retreat, I'm being forced back. I've lost the initiative. I can't continue forward. It's a strategic failure. It's a partial defeat. My resources are exhausted and I'm going to be demoralized by being forced back. But when I start to feel myself struggling, I can instead take the initiative by withdrawing from that engagement. Not necessarily permanently, but just hold back, regroup, rethink my strategy, pause for reinforcement and refueling. That keeps me in the center of controlling the initiative. And it allows me to be hopeful and optimistic in developing a different approach. And this is a key place where a mentor can help. When you start to feel yourself feeling a little overwhelmed, feeling a little struggled, not enough time, not enough energy, not enough optimism, this is a time to call for help, set up a meeting with your mentor, take a strategic withdrawal, and regroup yourself. Now back to the work-life balance again. I just want to remind you that discernment is essential for you to put that fence around those important but not urgent activities. Put in fun, put in personal growth, put in brainstorming, put in those relationships that feed your spirit. And brainstorm for renewal with your mentor. I had an Orthodox Jewish colleague who once said, Melissa, why don't most people take a Sabbath the way we do? He said that there was a whole day from sundown on Friday to sundown on Saturday where nothing but prayer and time with family, no TV, no work calls unless a person's on call, no cooking, no shopping, no driving. And I went, wow. And so I started a day a week where I didn't do any work. I focused on my family. I focused on my spiritual renewal. And it helped me so much. In the beginning, I thought, I can't come up with that time, but it fed me and gave me more hope and more optimism and actually better efficiency than if I hadn't been doing that. Exercise should be fun. Again, don't lift weights if you hate lifting weights. Don't go to the gym if you're feeling lonely. Why not take a walk with your spouse, partner, friends, crawl with your toddler? It doesn't have to be miserable. It's exercise, fitness should be fun. Honestly, whatever it is, you get to decide what you enjoyed doing as a kid. It could be swimming, it could be hanging from the monkey bars, it could be playing football. Walk with your partner, walk with your people at work, take a break from work and walk together, talk through problems while you get some exercise. Make sure you get enough water. Fatigue, in my experience, is often dehydration. Eat food that grounds you, not junk food, not just sugar and starch all day long. You need good quality protein, fiber. You need good quality fuel. If you're gonna, you need high octane fuel if you're a jet airplane, honestly. Putter, creative putter. A lot of my best ideas come when I'm not working, when I'm folding laundry, when I'm pulling weeds in the garden, when I'm just straightening things up on my desk. Often have a lot of creativity. So I call that puttering. And my husband says, it's time for you to do some puttering because it really helps me. Sleep, it's not a waste of time. My dad was a chair of pathology, very, very successful academic experimental pathologist. He needed 10 hours of sleep a night. I don't. I need about 5 or 6. Everyone's different, but sleep is not a waste of time. Know what you need and get it. And also remember those questions. What did you do for fun as a kid? That's going to be a helpful hint of how you can renew yourself now, whether it's playing with puzzles or taking pictures with a camera. You know what you have fun doing and what you had fun doing when you were a kid. And my dad used to say, you're never too old to have a happy childhood. He would sit down on the floor with my kids and play with toy trains. He loved doing that. So that fed him. And he used to always laugh, he got to be a child at a certain part of his day, all of his life long. And then finally find those friends who can be a mentor, maybe among your mentors, who believe in you and support your dreams. And with that, I want to thank you. You can feel free to direct message me on Twitter. My handle is @MelissaUpton7, or you can email me, mupton@uw.edu. Blessings to you all, and thank you very much.
I think it was a very informative talk, but was more boring than less than Dr. Mudassir's talk. Now everybody must be realizing how absorbing was Dr. Mudassir's talk. So this topic of medical, I am in the medical education these days, and this subject of medical education is really very boring and has added a headache to the head of the institute, this Department of Medical Education. What is the difference between curriculum and course, and what they keep confusing everybody. And it is really difficult to negotiate with them. Anyhow, this was more of a philosophical talk rather than a scientific one. Thank you very much. And if you have any questions regarding this Dr. Mudassir session, we can do it in 5 minutes.
Yes, so if the audience has any questions, kindly ask for the onconephrology. So I don't think that we have any online questions for Dr. Mudassir because Dr. Upton won't be joining us for question answer session. You can just send us those questions. We will get them your answers via email. And are there any questions online for Dr. Mudassir? So we had around 50 participants online for the talk, for Dr. Mudassir's talk. Less than 50. So I think this is, yeah.
Actually, when one gets fed up with the professional work done, then starts doing this medical education. I know one of our professor, Brigadier Lukman, very famous one.
So on this note, we conclude this second pathology session. I would like to thank again the chair, Dr. Shoaib Hashmi, for joining us today. It was an honor co-chairing with you. Thank you so much, Dr. Mudassir, Dr. Upton, for the sessions. And thank you, everyone.